This is the 2019 AHA-ACC focus update of the 2014 guidelines for the management of patients with atrial fibrillation. The exhaustive document is the 2014 guidelines, where they go through all the aspects of atrial fibrillation. And the 2019 is basically looking at the studies that were being done, the randomized controlled trials that were being done and have now been completed. And also there are a couple of medications that have been approved. So that is the reason for the updates. So let's look at what are some of these updates. Okay, so this is just to go over how we approach discussion of medical procedures, medication, or even the approach to patients. We class them, and we went over this before, but we have a class of recommendation, and everything we do, there's always a class of recommendation. You have a class 1 recommendation, so it's a very strong recommendation. As a matter of fact, this is usually the standard of care. Okay, it is recommended, and all, so class 1, and then you have a class 2. Class 2 is divided into class 2A. It is reasonable to do it, and you probably should do it. And then the class 2B, it may or might be reasonable, and you should do it. Even in the different class, there is a level of evidence, and this is the research material behind a lot of these procedures and medication. And then you have a class 3, and when we talk about a class 3 recommendation, those things that have no benefits, and then those things that are actually can harm the patient. So, so this is the approach that most of your medical discussion is going to take. So the recommendation for anticoagulation. So the anticoagulation regimen, when you gonna prescribe any type of blood thinners, you have to balance the risk and benefit. The risk for using the blood thinners is bleeding. It's always bleeding. And what the benefit prevents strokes or thromboembolism. So for patients with atrial fibrillation, and if they have an elevated CHA2DS2-VASc score, so you see, we're not using CHA2DS2 score anymore, we're using CHA2DS2-VASc score. So if the CHA2DS2-VASc score is 2 or greater in men, 3 or greater in women, then you can use any of these anticoagulants. Warfarin, level of evidence for warfarin is A, because warfarin has been around for a very long time, and we have used it extensively. We know a lot about warfarin. Then you have the NOACs, dabigatran, you're familiar with that. That is your Pradaxa. The level of evidence for that is B. Then we have rivaroxaban, which is your Xarelto, level of evidence is B. And then you have your apixaban, where the level of evidence for that, this is Eliquis. The level of evidence is B. The reason why this appears in the update is because edoxaban has been approved since the 2014 guideline, edoxaban, and this is Cerveza. Okay, so the last 3, these are factor 10A inhibitors. We went over the clotting cascade, so you know exactly where these medication work. And the dabigatran is your direct thrombin inhibitor. Okay, so these are medications that we currently have to offer. Again, when you use a CHA2DS2-VASc score, remember the CHA2DS2-VASc score is different from the CHAD score because the zero in the CHA2DS2-VASc score is a real zero. The chance of thromboembolism is close to zero. Okay, but if you have a CHA2DS2-VASc score in a male greater than or equal to 2, they should be anticoagulated. And then for female greater than or equal to 3, they should be anticoagulated. Remember, females carry a slightly higher risk, and that is why once it's a female gender, they have that gives them a score of 1. So the NOACs, again, if you want to call it the novel or the newer oral anticoagulant, which includes dabigatran, rivaroxaban, apixaban, and edoxaban. So they're recommended, currently they're recommended over warfarin if the patient is eligible, in a NOAC eligible patient with atrial fibrillation. So especially physicians doing exams, the gold standard now is the NOACs once a patient is eligible. So it's no longer warfarin, okay? Except, and then the exception is important. When we talk about valvular AF, you know, in the old document, we talk about mitral valve repair, we talk about mechanical mitral valve, and then we talk about mitral stenosis, and we didn't give any severity. The current definition, however, is moderate to severe mitral stenosis or a mechanical a heart valve. So that is the definition for valvular atrial fibrillation. Remember, our discussion here is mainly non-valvular AF. And what we mean by that is the atrial fibrillation did not occur because of some valvular pathology. And the valvular pathology that we're talking about is moderate to severe mitral stenosis or a mechanical mitral valve. Okay? So you cannot give NOACs to these patients. But the important thing here is that the NOACs are now recommended over warfarin. Okay? They're very expensive, so depending on where you're practicing, you may still want to use warfarin. But in terms of the class of recommendations, a class 1 level of evidence is A. So you know, people doing the exam, the NOACs are the gold standard at the present time. So among patients treated with warfarin, if the INR, so you have a patient and you're treating them with warfarin, the INR should be done weekly initially. So when you start in the warfarin, you want to do it weekly until you get to your therapeutic range. And then once you get to your therapeutic range, then you do your INR monthly. So once a patient is stable, you do the INR monthly. But the initial treatment, you're going to do your INR on a weekly basis. Now, again, we're talking about non-valvular atrial fibrillation. And when you see atrial fibrillation, it's going to be either valvular or non-valvular. And the current definition for valvular is your moderate to severe mitral stenosis or a mechanical valve. So the recommendation for selecting anticoagulants, you have to balance the risk and the benefit. So you have to the bleeding risk versus the stroke risk. So in patients with atrial fibrillation, you have to use the CHA2DS2-VASc score for the assessment of stroke risk. So it is no longer CHAD score, it's CHA2DS2-VASc score, okay? And if the patient have a mechanical heart valve, the only thing you can use is warfarin. The only medication you can use if the patient have a mechanical heart valve is warfarin. So again, whenever you're doing your therapy, the risk of bleeding have to be entered into the equation. Because if the patient have a very high risk of bleeding, you don't want to give them the anticoagulant, okay? So regardless of what type of atrial fibrillation the patient presents with, paroxysmal, persistent, or permanent, you treat them the same way, and they're going to be risked the same way using the CHA2DS2-VASc score, okay? Now, renal and hepatic function should be evaluated before you initiate the NOACs, and it should be re-evaluated at least yearly. If you remember, when we look at the NOACs, your rivaroxaban, your dabigatran, and your edoxaban, those are renally eliminated. They're eliminated through the kidneys. So you have to follow the kidney function. Your apixaban, however, which is your Eliquis, it is mainly eliminated through the liver, and hence you have to get hepatic function. So at the initiation of the therapy, you get your kidney function, your liver function. So you get a BMP and an LFT, or electrolyte panel and an LFT, and you can do that once a year. And you might have to adjust your dosing periodically depending on what the liver function or the renal function is. So when you treating a patient, you have to individualize your patients. Don't use any broad, don't use a very broad brush to making a decision. So your decision should be individualized, looking at the absolute risk, the relative risk of stroke and bleeding. You always have to take into consideration bleeding, okay, and the stroke risk. If the stroke risk is very, very low and the bleeding risk is very high, then you probably don't need to anticoagulate the patient. And you have to discuss this with the patient, however, okay? So your therapy should be individualized. Know the guidelines, though. You have to know the guidelines. So your atrial flutter is going to be anticoagulated in the same fashion as your atrial fibrillation. You're going to put them through the CHA2DS2-VASc score, and the therapy is the same. So atrial flutter is not treated any different. Okay. And we mentioned this before. So you have to reevaluate the patient periodically, and because things may change the renal function may deteriorate, hepatic function may deteriorate, so you may have to change the medication to something else, or you may have to modify the dose. All right. So for non-valvular AF patients, for patients with AF, accept these conditions, who are able to maintain a reasonable therapeutic range with your warfarin, then you should use the NOACs, because the time in therapeutic range for warfarin sometimes is very, very low. And if you cannot adequately, if the patient cannot maintain a reasonable INR, then it don't make any sense you continue the warfarin. You just switch them to the NOACs. Okay? But this is for non-valvular AF, that is, they don't have moderate to severe mitral stenosis or mechanical valve. This is now a little tricky. Well, it's not really tricky for physicians who treat patients with atrial fibrillation. This update is very important, because remember what we said about your CHA2DS2-VASc score. Now we're using CHA2DS2-VASc score. 0 is probably a real 0, and a female really cannot get a 0, because the mere fact that they're a female, they start with 1. So, a score of 1 in a female is essentially a 0. But anyway, so if the CHA2DS2-VASc score for a man is 0, and that for a woman is 1, it is reasonable not to give them any anticoagulant. Okay? So, you won't be well, since it's in the guidelines, docs doing exams can be tested on this. So, if it's a male with a CHA2DS2-VASc score of 0, you don't have to give them. Female with a score of 1, you don't have to give them any anticoagulant. Again, remember, the mere fact that the female is it's a woman. Okay, so remember, in the CHA2DS2-VASc score, the VAS is the sex category, and females get a score of 1. So female cannot get a score of 0. Okay, can't get a score of 0. So before before the studies came out, we were a little bit unsure what to do with some of these patients, but it is fairly clear now you don't have to anticoagulate them. So the ones that you're going to anticoagulate is a male with a CHA2DS2-VASc score greater than or equal to 2, and a female greater than or equal to 3. Okay, so make sure that's very clear. Now, if there is renal compromise, so there's kidney problem. So if there's kidney problem, you do your risk profile. Again, greater than or equal to 2 for men, greater than or equal to 3 for female. If the patients have end-stage chronic kidney disease, okay, you can use warfarin is okay, or apixaban. So most physicians would go to apixaban. This is Eliquis. So remember, Eliquis is mainly eliminated through the liver. So even though you have end-stage kidney disease, creatinine clearance less than 15 mL per minute, or if the patient is on dialysis, it's okay. You can use either warfarin or apixaban. So again, physicians do an exam. This is important. So the patients on dialysis, chronic they want you to know that you can give them Eliquis, apixaban. Now, if it's not end-stage kidney disease and you have renal compromise to some degree, you can use the others, but you have to adjust the dose. So for dabigatran, which is your Pradaxa, if the creatinine clearance is between 15 and 30, then you adjust the dose, 75 milligrams BID. If your rivaroxaban, if the creatinine clearance is less than or equal to 50, then you want to use 15 milligrams. And then Cerveza, 15 to 50. Okay. Of course, they have to have an elevated CHA2DS2-VASc score, which warrants using anticoagulants. Okay. So the important point well, those medicines that are eliminated by the kidney, you have to adjust the dose if the patient have any type of kidney failure. Okay, you need to know the adjusted dose. Remembering that Eliquis or apixaban, you don't have to do any adjustment for those patients. And you can use warfarin as well. So we talking about borderline patients now. So the CHA2DS2-VASc score in a man now is 1, and in a female is 2. So these are really borderline. We're sort of straight. When the CHA2DS2-VASc score for a male is 0, you don't have to give him any anticoagulant. Female, 1, you don't have to give her. But so these are now in the gray zone. So if the CHA2DS2-VASc score in the man is 1 and the woman is 2, you may use the oral anticoagulant to reduce thromboembolic stroke. You may use it. So you have to sit down with the patient and tell them that they're in this gray zone, and there may be benefit. Okay. However, there is no gray zone if the CHA2DS2-VASc score in a man is greater than or equal to 2, and in a female greater than or equal to 3. No gray zone there. The gray zone is CHA2DS2-VASc score of 1 in a man, 2 in a woman. Okay? Remember, CHA2DS2-VASc score of 0 in a man is clear cut, no anticoagulant. CHA2DS2-VASc score of 1 in a woman, clear, no anticoagulant. So try and get that straight, okay? So again, if there is renal compromise problem with the kidneys, you just have to adjust the dose of the medications that are eliminated through the kidneys, and that's your rivaroxaban, your edoxaban, and your dabigatran. Okay. So if you remember, when we did the 2014 guidelines, there was a study that they compared dabigatran to warfarin in patients with mechanical valves, and that study had to be stopped prematurely because there's a lot of deaths in the dabigatran harm, heart attacks and stuff like that. So that study was completed. So the direct thrombin inhibitor dabigatran should not be used in patients with AF and a mechanical heart valve. So that's where that comes from. Okay, so you already know that. The NOACs are not recommended for non-valvular AF. What about bridging? So Bridging is when the patient is taking an anticoagulant and you want to stop it to do some procedure that may put the patient at increased risk of bleeding. If you leave them on the anticoagulant, and then if you stop the anticoagulant and don't put them on any blood thinners, it increases the risk of a stroke. So you have to know which patient you're going to bridge, okay? Which patient you're going to bridge. That is, you're going to stop the blood thinner and you're going to give them either intravenous heparin or low molecular weight heparin. Remember what we said about these medicines? They're very short acting, they're intravenous. Once you stop the infusion or stop the injection, the effect goes away relatively quickly. So you can do whatever procedure you want to do and then put them back in it. All right, so bridging therapy with unfractionated heparin, which is your regular heparin, or low molecular weight heparin is recommended for patients with atrial fibrillation and a mechanical heart valve. So if the patient have a mechanical heart valve, those patients should be on warfarin. Those patients don't get NOACs. They have to get warfarin. Warfarin prevents blood clotting on top of the mechanical prosthesis. So if you're going to do a procedure that there's potential of bleeding, you should stop the warfarin and then you're going to bridge them, okay? So you can bridge them with unfractionated heparin or low molecular weight heparin. However, the decision on bridging you have to look in terms of the risk of stroke versus the bleeding risk. So you always have to look at those those two risks, the stroke risk and the bleeding risk. Okay. Again, for patients with atrial fibrillation without mechanical heart valve, interruption of warfarin procedures, decision about bridging again, you're going to look at the risk of stroke versus bleeding. The good thing about the NOACs, so if the patient has atrial fibrillation without mechanical heart valve or without moderate to severe mitral stenosis, if you stop the dose of the NOAC, you can do your procedure within 24 hours if the renal function is okay. If the renal function is impaired, then you might want to wait 48 hours. So the NOACs are a little bit different, but remember the effects of warfarin last 5 days, 7 days. So you always have to look at the risk of stroke versus the risk of bleeding. Now, when the 2014 guidelines came out, there weren't any antidote to the NOACs. There weren't any antidotes to the NOACs. So one of the problems when you use blood thinners, some patients can bleed profusely, and you need to have something to reverse the effects of the anticoagulant. For warfarin, we can reverse the effects of warfarin. If the patient starts bleeding profusely, we can reverse the effects of warfarin. We can give them vitamin K. If you need to reverse it a little bit quicker, you can give them fresh frozen plasma. Okay, replace the clotting factors. The problem with the newer agents, we didn't have anything to reverse the bleeding, and that is why some physicians were reluctant to use it because there weren't any reversing agents. Now we have a reversing agent. So for dabigatran, Pradaxa, the reversing agent is edoxarucizumab. So that is the reversing agent. So it's now available. It is recommended for reversal of dabigatran only for life-threatening bleeding or an urgent procedure, if you're going to do an urgent procedure. So you can't just routinely get it. It is extremely, extremely expensive. And we're talking upwards of $20,000 per vial. And then for rivaroxaban and apixaban, you have andexanet alpha. So this is a reversal agent. So these are relatively, well, the reversal agent for the factor 10A, relatively new. The ones for dabigatran has been around a little bit. Okay, so these are the reversal agents for these medicines. Very, very expensive. So it's you have patient is bleeding. You still need to get approval. There's a committee that will decide. So all right. So what we did discuss non-pharmacological stroke prevention. We had Dr. Gaynor and Will Miller look at it. So the percutaneous left atrial appendage occlusion may be considered in patients with AF, an increased risk of stroke, who have some type of contraindication to long-term anticoagulation. So we have a lot of these patients. They have increased risk when you put them in the CHA2DS2-VASc score, increased risk of stroke, but they fall risk and hit their head and have an hemorrhagic stroke or whatever. So those are some of the patients that would benefit from percutaneous left atrial appendage occlusion. And the FDA approved Watchman device. So that we use that fairly extensive at the present time. Surgical occlusion of left atrial appendage may be considered in patients with AF if they're undergoing cardiac surgery. So it is not recommended to just do a de novo surgical occlusion of the left atrial appendage. If you're going to do, say, bypass or you're going to do some other cardiac surgery, then you can do it. And a lot of the procedures that we do now, cardiac-wise, we have a heart team approach. So the surgeon, the cardiologist, and the EP, sit down and make these decisions. All right. So rhythm. So updates for atrial fibrillation, atrial flutter, 48-hour duration or longer. Remember, we said it takes 48 hours to form clots. So that's the time frame that will be mentioned. Or if the AFib duration is unknown, the recommendation is to anticoagulate them with warfarin, INR between 2 and 3, or you can use your factor 10A inhibitor or your direct thrombin inhibitor for 3 weeks. So remember, you have to anticoagulate these patients for 3 weeks before, before you do any type of cardioversion, and at least 4 weeks after the cardioversion, regardless of the CHA2DS2-VASc score or the method of cardioversion used. So this is another update. So patient comes in, AFib, A-flutter, you're not sure of the duration, regardless of the CHA2DS2-VASc score. They say you should anticoagulate them for 3 weeks before you do any cardioversion, whether it's chemical, pharmacological, or electrical, and then you anticoagulate them at least 4 weeks after the cardioversion. So that's a class of recommendation one, level of evidence B. So for patients with atrial fibrillation, atrial flutter of more than 40 hours duration or unknown duration that requires immediate. So now you're going to cardiovert them immediately because they may have some type of hemodynamic instability. You try and get, this is not so new, but you try and get the anticoagulation on board as soon as possible. Okay, so even 30 minutes before you do your cardioversion, and then you're going to anticoagulate them for at least 4 weeks after the cardioversion, unless it's contraindicated. Okay, so unless there's contraindication, you try and anticoagulate these patients. Okay. So after your cardioversion for atrial fibrillation of any duration, so you're going to make a decision about long-term anticoagulation, long-term blood thinner. Again, you're going to have to do the risk of stroke and the risk of bleeding. The stroke risk, you use your CHAD-VAS score, and the bleeding risk, you can use the HAS-BLED score for bleeding risk. So you have to weigh the risk of developing a stroke versus the risk of bleeding. Okay? So you always have to do that. And remember, an elevated score is a score of 2 or greater in men or 3 or greater in women. Okay? And then you can give them, the current recommendation is the NOACs, unless there's some contraindication. So the NOACs are the preferred agents over warfarin at the current time. Okay. So again, we do a lot of this. So for atrial fibrillation, atrial flutter of 48 hours duration or longer, or you don't know how long the patient has been in atrial fibrillation, and if they were not anticoagulated for 3 weeks. So the scenario I painted, patient comes into the hospital tonight, and I go to the I go to the cardiac unit tomorrow, and I have a bunch of patients who came in atrial fibrillation. We don't know how long they've been in atrial fibrillation. Yeah, they're gonna put them on blood thinners. That's one thing, they put them on blood thinners. So it is, I will do a transesophageal echo tomorrow morning, and if there's no clots, then do cardioversion. Okay, if there is clots, then I'm going to anticoagulate them for at least 3 weeks. Okay, if I cardiovert them, then we're going to put them on blood thinner for at least 4 weeks after the cardioversion. So that is now standard, but it still has a class 2A class of recommendation and level of evidence B. So even though we do this almost routine, it don't have a class 1 indication, still class 2. All right, and then for patients with atrial fibr, atrial flutter of at least 48 hours duration, and they have a CHAD-VAS. So now these are the real low risk patients. So remember, CHAD-VAS score patient in AFib, AFib, but the CHAD-VAS score in the man is 0, in the female is 1. It cannot be 0 in a woman. So very low risk. Then you don't have to anticoagulate them. Okay, so you don't have to anticoagulate them, and you don't have to put them on long term. Yeah, if the patient says to you, I had a relative who, did this approach and they had a stroke, and I want, it's the patient wants it, yes, but you don't have to anticoagulate them. Okay, so that was good. All right. So what about AFib catheter ablation to maintain sinus rhythm? So remember we do catheter ablation. So atrial fibrillation catheter ablation may be reasonable in selected patients with symptomatic AF. So if the patient comes in, atrial fibrillation, uh, and they have an ejection fraction say 30%, and they're in heart failure, you you can do a catheter ablation and to reduce the burden, the AF burden, and this strategy may potentially lower the mortality rate and reduce hospitalization. So this is something relatively new, and it has a class of recommendation 2B. So, what we're saying is that patient have atrial fibrillation ejection fraction. So the low ejection fraction is probably not tachycardia induced cardiomyopathy, but they may have a reduced ejection fraction for some other reason. They develop atrial fibrillation. It is reasonable to do catheter ablation to potentially lower mortality and reduce hospitalization. Because atrial fibrillation is going to precipitate these, going to cause these patients to go into heart failure. Let's look at some specific groups, and we're going to sort of. So an important group is patients with acute coronary syndrome. And when we talk about acute coronary syndrome, patients with non-Q wave heart attacks, unstable angina. So if a patient with acute coronary syndrome and they have an increased risk of systemic thromboembolism using the CHA2DS2-VASc score, you should give them anticoagulant unless the bleeding risk exceeds the expected benefit. If the bleeding risk is very, very high, you may not want to give them anticoagulants, but you're expected to give them anticoagulants even though they're going to be on antiplatelets. Okay? So if you do urgent, it's reasonable if the patient is in acute coronary syndrome, and they're new onset AF, it's best to just shock them out of it. So especially if they're hypotensive, if they're having ongoing chest pains from ongoing ischemia, or if their heart rate is very high, it's best to just shock them, get them out of it, and so that you can adequately manage the acute coronary syndrome. Some other points: if the patient have acute coronary syndrome and they're not in heart failure, the blood pressure is not too low, and they're not wheezing or anything like that, then and they have AFib as well, you can use intravenous beta blockers to slow the ventricular response. So we usually say if there's any evidence of increased sympathetic tone, you can use IV beta blockers. So patients with AF and they have acute coronary syndrome, as long as they don't have heart failure and the blood pressure is okay, they're not wheezing too much, you can use intravenous beta blockers. Okay. Now, this is a little tricky because patients with acute coronary syndrome, and if you put in a stent, when we put a stent in, patients need to be on dual antiplatelet therapy for at a minimum of 3 months. For acute coronary syndrome, probably more like 6 months. So we put them on something like aspirin and clopidogrel. Okay, those are antiplatelet medicines, and we talk about dual because they need two to prevent stent thrombosis. But if they have atrial fibrillation now, they have to be on an anticoagulant. And all of this antiplatelet and anticoagulant increase the risk of bleeding. So if you put a stent in, okay, triple therapy, which is aspirin and a P2Y12, such as clopidogrel, and an oral anticoagulant therapy, um, you know, should be prescribed if the patient have AF and have an increased stroke risk. Again, the stroke risk is based on the CHA2DS2-VASc score of 2 or more, okay? And again, so these are patients who have a, you put a stent in, okay? What they're saying, you probably should use clopidogrel instead of prasugrel, okay? Prasugrel is associated with more bleeding, so you probably should use this. I'm not sure that, these type of questions probably would be reserved for cardiology fellows, but just for clinical practice, you have a patient, atrial fibrillation, they have a stent in place, and you want to know what medicine to put them on. You wouldn't give them prasugrel. You put them on aspirin, clopidogrel, and whichever anticoagulant you want to use. And you can do this for probably 3 months, and then after 3 months, you drop the aspirin. Okay. So it sounds a little bit messy, but if the patient have a stent in place, you should give them dual antiplatelet therapy. So a stent, aspirin, you can use clopidogrel, ticagrelor, whatever. They need 2 platelet medicine with a stent. If they develop atrial fibrillation now, then you're thinking in terms of an anticoagulant. And that's when it becomes very tricky because it can bleed. You have too many, blood thinners on board and they can bleed. So you have to follow these patients carefully. So if you look at the CHA2DS2-VASc score and the CHA2DS2-VASc score is high, then you should put them on an anticoagulant. What you need to do after 3 months, you can drop the aspirin. Okay. So let's see. And then this is another recommendation that patients have acute coronary syndrome. You have to put a stent in. So by the mere fact you put a stent in, they need 2 antiplatelet drugs. Clopidogrel and an aspirin. Okay. Clopidogrel and aspirin, and if they have atrial fibrillation, then you have to put them on an anticoagulant. There's a recent study that showed that you can reduce the dose. You can give them Xarelto, rivaroxaban, or reduce the dose. Okay. The best thing if you have a patient who have acute coronary syndrome and you start putting on a lot of antiplatelets and stuff, you just look up the guidelines because you might not remember it. A very rough guide though is initially you can give them the triple therapy. That is your 2 antiplatelets and your anticoagulant. But after 3 months, just drop the aspirin. Just, that's a very simple way of looking at it. After 3 months, just drop the aspirin. Other than that, it starts getting very messy and you might not remember what. Okay, so another recommendation, only class 2B though, again, we're still with acute coronary syndrome. If the patient have acute coronary syndrome and they have LV systolic dysfunction, ejection fraction 30% and their heart failure, instead of using a beta blocker or a calcium channel blocker to lower the heart rate, you can use amiodarone or digoxin to lower the heart rate of these AFib patients. Um, you know, so you don't want to use your non-dihydropyridine calcium channel blockers if the patient have atrial fibrillation and heart failure. We went over this again. We went over this before. So once a patient is in heart failure or they have heart failure with reduced ejection fraction, you don't want to use your diltiazem or your verapamil. So that's the, and we sort of winding down now. So if the patient have a device in, so so patients who have multiple heart problems and have pacemaker, those are the patients who develop atrial fibrillation. So the patient may have a pacemaker in place or an implanted converted defibrillator. And if these devices show that there is high atrial rate, you should evaluate the patient more to see if they're having atrial fibrillation, because if they have atrial fibrillation, it's going to change your treatment strategy. So remember, these devices that the patient have in place, they not only have a therapeutic role, but they also monitor. And if the patient have a high atrial rate, so high atrial rate could be, supraventricular tachycardia, it could be atrial flutter, atrial fibrillation. But if it's atrial fibrillation or atrial flutter, it's going to change the patient management. So you need to evaluate the patient more. And then also patients with what we call cryptogenic stroke. Patient have a stroke and you don't know why they have a stroke. It is reasonable to put an implantable loop, one of these cardiac monitor. It's a loop recorder to see if the patient have silent atrial fibrillation. Remember, atrial fibrillation is associated with a lot of strokes. So if the patient have a stroke and you don't know why they have a stroke, you can put one of these loop recorder in place and evaluate it periodically. And then weight. Remember, weight loss in patients with atrial fibrillation is crucial. It can reduce the frequency of AF, and it makes the AF management much better. So these are the updates, and some are very helpful in just everyday management of these patients. Some are a little bit more esoteric.